Good morning, everyone, and welcome to our 2019 State of Health Equity at CDC Forum, Building Equity and Community Resilience in Public Health Emergencies, sponsored by the Office of Minority Health and Health Equity. I'm Craig Wilkins, Senior Advisor within the office, and I'll be serving as your forum moderator. It is an honor to welcome each of our special guests, speakers, and discussants, and to each of you for joining us this morning, and for those of you joining us by IPTV. As noted on the agenda, the purpose of today's forum is to apply a health equity lens to public health emergency preparedness, response, and recovery activities through deliberate communication and interdisciplinary partnerships. I had the pleasure of being part of a small planning committee that put this forum together. My sincere appreciation and gratitude is extended to each of them for all of their hard efforts in the planning of this year's event. Their names are printed on the agenda, but I would like for them to stand as I read off their names very quickly and then recognize them with a round of applause. Dr. Leandris Liburd, Dr. Boyer, Captain Deron Burton, Julio Decent de la Pierre, Kayla Johnson, Ma O'Heary, Captain Bobby Rosalunia, Dr. Ross, who's not here today, Dr. Aaron Thomas, Dr. Patty Tucker, Joe Valentine, and Dr. Amy Walken. So again, on behalf of this committee and our office, we appreciate your attendance and participation. On today's agenda, we'll have two opening presentations and then two panel discussions consisting of two presenters and a discussant. The discussant will be providing brief reflective comments after the panel presentations and then facilitate a 15-minute question and answer session. At the end of the second panel discussions, we will have a closing synthesis panel where each of the presenters will be invited back up to share any final comments and recommendations and to answer any final questions. Before we begin today's forum, a few housekeeping items. If you didn't register before you came in, please do so. For those of you who are participating by IPTV, you will be able to email your questions to omhhe@cdc.gov. We have staff who will be monitoring this for questions. On the agenda, you will also note we will have one official break, and although it's a short break, we would appreciate you being respectful of the time, returning back to the room since we want to stay on schedule as much as possible because we have a full agenda. If you need to step out before then or afterwards, we would ask you do so in between the presentations and panel sessions to lessen distraction for our presenters. On behalf of the office, we would appreciate you completing and returning a brief evaluation that's designed to provide feedback about this forum. If you are registered for the conference, you will receive a link to an evaluation survey in your email box. For those viewing the forum on IPTV, we may not have your registration information, so please go to OMHHE's intranet site, click on Events, then click on 2019 C Forum, and the survey link will be at the top of the page. The evaluation will be available right after the forum ends today and will be open until next Friday, February 8th, up until 5 o'clock p.m. for you to submit your responses. We really value your feedback, and your responses will be completely anonymous. For those of you interested in continuing education credits, you can look on the screen or note on the back of your agenda the link where they will be available. The activity and passcode is also noted there as well. And if you haven't already done so, please silence your electronic devices. Throughout this morning, I'm here to answer any questions that you might have. Now, I have the distinct privilege of introducing you to Dr. Leandris Liburd and Rear Admiral Dr. Red. Dr. Liburd Dr. Bird currently serves as Director for the Office of Minority Health and Health Equity at CDC. And Rear Admiral Stephen Redd is Deputy Director for the Public Health Service and Implementation Science and also serves as Director of the Center for Preparedness and Response. Please welcome them for the opening remarks.
Good morning, everyone. And I add my welcome to Captain Wilkins to the 7th State of Health Equity at CDC Forum. We couldn't be more excited or more pleased by the response to this year's forum that will situate public health preparedness and response in a community-centered health equity framework. I think yesterday I was told we had around 270 registrants, and that's absolutely a record for us. And so we're very excited about the interest and the participation. I also want to thank our guest speakers for their participation in this important convening and for their willingness to share lessons learned in emergency preparedness from a variety of unique perspectives. I also want to acknowledge Captain Wilkins and his leadership in bringing together the planning committee and building the kind of relationships we need to advance the science and practice of health equity at CDC. So please join me in giving him a hand. So for those who are new to the forum, what is the state of health equity at CDC Forum? We describe it as an agency-wide assembly to examine CDC's progress in the implementation of policies, programs, surveillance, and research that contributes to reducing health disparities and achieving health equity. Pursuing health equity is, relatively speaking, a more recent goal in public health. For some, it is viewed as an aspiration, a lofty vision. And for others, it is a definable set of actions that, when taken together, create communities where all people have the opportunity to attain the best health possible. We come to the pursuit of health equity at the intersection of action and aspiration. For example, to advance health equity at CDC, we must first believe that it is possible for all people to attain their best health possible. And then we must identify indicators, measures, and tools for monitoring trends in health disparities and health inequities. We must identify criteria based on the best available evidence for best practices in achieving health equity across a range of public health conditions. We must promote policies that support reducing health disparities and achieving health equity. And we must clarify and promote organizational structures that facilitate the integration of health equity in programs and research. The presentations that we will hear today will provide real world and actionable examples of what it means to apply a health equity lens in public health emergencies. I look forward to all that will be shared today and how we might use this knowledge to achieve CDC's mission. So welcome again, and I know you're going to get a lot out of today's gathering, and thank you for your participation.
Good morning, everyone. Let me welcome everyone to this forum on behalf of Dr. Redfield. This, as Leandra described, this is one in a series of meetings to try to bring focus to our work in eliminating health inequity or bringing health equity to our nation. And it really is a testament to our belief that we have to take deliberate action to improve health equity, that this is not something that is going to happen on its own, that our overall public health efforts are going to somehow achieve health equity without that deliberate action. I think this is a case where the rising tide doesn't necessarily rise all boats, and so today's meeting is a way to bring some focus to that. I would like to say that we really are needing to put more energy into this in the domain of preparedness and responses to health emergencies. When I worked in the influenza coordination unit, it was a big part of our activity, and I felt that we really hadn't achieved what we needed to in order to make sure that when a pandemic came, we had really done everything that needed to be done. I would say that in a health emergency, the kind of the currency that we need to address is that of information. That people need information to take action to protect themselves and to do the things that will reduce the impact of a health emergency. And there are two barriers that we face and that we need to overcome in working on in the health equity zone. The first is one of trust, and for historical reasons, the lack of confidence that many populations have that when the government or the establishment recommends a certain course of action, that's what you really should do. So that area of trust is very important. The other area is one of capacity. So if you don't have access to transportation and the recommendation is to evacuate, that's going to be a problem. So I think that that's another area that we need to work on, is making sure that when we make a recommendation, the groups that we're making the recommendation actually have the capacity to do the thing that they're being recommended to do. And that can be a functional limitation, or it can be a access to resources. So again, let me welcome everyone. I want to especially welcome our guests who have traveled from afar. Dr. Rodriguez from Puerto Rico, Mr. Stripling from New York City, and I don't see Dan Dodgen out there from Washington, but he's on the agenda, so I'm assuming that he'll be here as well. Thanks very much.
Our first presenter this morning, as he comes forward, is Dr. Amy Walken. Dr. Walken is the Senior Advisor for At-Risk Populations here at the Center for Preparedness and Response here at CDC. Dr. Walken focuses on improving the resilience of at-risk populations to natural and human-caused disasters, disease outbreaks, and other adverse events. She provides scientific expertise for emergency preparedness and response activities. Since joining the CDC in 2002, Dr. Walken has led numerous national and international outbreak investigations and emergency responses. Her research experience includes vulnerable populations and emergencies, health impacts of extreme weather events, community health assessments, chemical and radiological terrorism, and toxic epidemiology. Hard to say that word. Dr. Walken has authored more than 75 peer-reviewed articles and book chapters on disaster epidemiology, environmental epidemiology, and surveillance. She received her doctorate of public health from the University of North Carolina at Chapel Hill, her master's of science in public health from Emory University, and her bachelor's degree from the University of Georgia. Please join me in welcoming Dr. Walken.
Thank you, Craig. Good morning. I'm Amy Walken. I'm the Senior Advisor for At-Risk Populations with the Office of Science and Public Health Practice the Center for Preparedness and Response. This morning, I'm going to talk about preparing and responding to emergencies through a health equity lens. And the goal is to frame the rest of the talks that we're going to hear this morning. So before I talk about the subject, I always like to talk about terminology, because a lot of people like to use different words and are comfortable with different terms, and want to make sure that we're all on the same page for which parts of the population we're trying to address. So at-risk populations refer to individuals or groups of people who may not be able to access and use the standard resources offered in emergency preparedness response and recovery. And we know from previous emergencies, and we see this for every single emergency, regardless of the type, and including the most recent hurricane emergencies that we went through, have shown that there are certain groups of people that face disproportionate risks. Some people like to use the term individuals with access and functional needs. You'll hear this term from FEMA and from ASPR, and in the next few slides, I'll go through that term. And sometimes we just group them all together and talk about populations that are specifically at risk, and I'll explain why we do that as well. So access and functional needs address a broad set of needs irrespective of a specific status, diagnosis, or label. This term is very useful when you're trying to allocate resources and you need to know what exactly the needs are. So for example, if you have American Red Cross shelter and you're triaging people coming in, knowing that an older adult is coming in doesn't tell you a lot of information, doesn't tell you what their needs are. However, if we can look specifically at their access needs or their functional needs, we can know where to allocate those resources. So access needs are based on access to social services, accommodations, information, transportation, medication. And function-based needs are restrictions or limitations on an individual that may require assistance before, during, or after an emergency. And often the CMIST framework is used to determine who these people are. And so CMIST stands for communication, maintaining health, independence, support and safety, and transportation. Communications. This is individuals who may have limitations that interfere with the receipt of and response to information. So for an example, this may include individuals who are deaf or hard of hearing. If they cannot hear the information that we're trying to give them, they cannot take protective actions. Likewise, individuals who have limited English proficiency. So it's important that we're pushing out our messages in the languages that people are speaking, but not just to make translations, but to have cultural translations as well. We need to make sure that our messages are in line with their culture and our interventions are in line with the cultures as well. Maintaining health. So individuals who require assistance in managing their chronic disease, receiving medication and treatment, or operating medical equipment to sustain life. Domestically, from natural disasters, the thing we see the most in emergency is exacerbation of chronic disease. And so we need to think about what we can do for these populations. So we might think about individuals with chronic disease. We might think about pregnant, postpartum women. So this brings up a good point that these vulnerabilities are temporary. They may not be something that you have over your lifetime. And during the course of your life, this may change. You may have a certain vulnerability that you have today that you don't have tomorrow. Independence. Individuals who function independently as long as they are not separated from their devices, assisted technology, or service animals. So for an example, we might have individuals with a disability or older adults. Support and safety. This is individuals that require additional personal care assistance, experience higher levels of distress, or support for personal safety. So this includes both your physical health as well as your mental health. This may include groups of people like children, depending on their age and their developmental abilities, and individuals with cognitive limitations. And finally, we have transportation. This one's pretty self-explanatory. Individuals with transportation needs because of age, disability, injury, poverty, legal restriction, or those without a vehicle. So you see there's health reasons that factor in here. There's social reasons that factor in here. So this might include persons who are dependent on mass transportation or persons with disability. So the CMIST framework allows us to figure out who these people are, especially during a response. However, it can be difficult ahead of time when you're in the planning stage to figure out who fits nicely into these buckets. We don't have very good databases for this. We have some databases. For example, we have Empower, which is a HHS tool that has Medicare beneficiaries that are electric dependent. Now, that only includes about 2.4 million people, so that's a small amount of people that we're thinking about when we're thinking about at-risk populations. So we also talk about populations in whole because these numbers are a little bit easier to enumerate. We can use databases that we have, such as the census and other surveys, to figure out who fits into specific categories based on socio-demographic characteristics. And we know that there are certain populations, these may be referred to as at-risk populations or vulnerable populations. Some people don't like those terms. A lot of people do not like to consider themselves vulnerable. But we do know that these populations suffer disproportionate harm in a disaster. So we might be thinking about children, older adults, racial and ethnic minorities. And this population approach allows planners to enumerate these populations based on census data and other surveys. And we have tools such as the Social Vulnerability Index, which we'll hear Dr. Bracci talk about in a few minutes. It's also important to consider that each of these vulnerabilities I'm talking about are overlapping and intersecting, so we cannot think about them separately. But race, poverty, access to healthcare, for example, overlap, and we have to think about their interrelationship to one another. So now I want to move into talking about inequities and emergencies. So we know that there is unequal access to resources and opportunities in this country. That is also coupled with unequal exposure to hazards. For example, low income and predominantly minority communities may have less access to resources in terms of wealth, power, or healthcare. Those same populations may be more prone to a natural disaster and other threats. So, for example, communities of color are often situated in vulnerable areas as a result of discriminatory housing practices. This has happened both historically and is still happening today. Hurricane Katrina cut across racial and socioeconomic lines. We know it impacted much of New Orleans. However, neighborhoods and people with the most severe damage were communities of color living in poverty and lacking services and infrastructure needed to recover. So not only are certain populations being impacted more during the actual event, but it's also more difficult for them to cope or to recover due to a lack of access to resources afterwards. So I want to bring up this map that shows the intersection of vulnerability and hazard. And I pulled this from the National Environmental Public Health Tracking Network, which sits in the National Center for Environmental Health, where Dr. Bracci leads. And I pulled up two maps. One came from the Social Vulnerability Index, and I pulled up the poverty score for Georgia. And you'll see the areas in yellow are areas of high poverty. And then I pulled up the flooding map. And so these are the areas that are more likely to flood, and the dark orange are those areas more likely to flood. And you'll see the intersection between the two areas. So those who have less resources are also more likely to experience a flooding event. So now I want to talk about a health equity lens. As you heard Dr. Liebert say, that we are starting to apply a health equity lens to chronic disease management, to disease management that has been recognized. And now we want to move to apply the same lens to public health emergency preparedness, response, and recovery. And this is to address disparities to ensure that we're not inadvertently creating them during our response and our recovery and our planning activities, and also that we're not exacerbating them during an emergency. So there's underlying vulnerabilities, and we want to make sure that we're not exacerbating those. So there's many barriers to address disparities and vulnerabilities. I'm just going to highlight a few, and Dr. Red had mentioned some of these. One of this is a layered disaster. So as I mentioned earlier, hazards tend to harm segments of the population that were already disadvantaged before a disaster. There's differential vulnerability for people by where they work, where they live, and where they play. Government mistrust, this is what Dr. Red brought up, that there is historical and current mistrust of the government and institutions. So if we're using these, the government and certain institutions to get out our messaging, they may not be received because there's not a trusting relationship there. Diverse communities often do not feel respected, and they may not have the political power to garner their necessary resources. Organizational resilience. There's a lot of organizations out there that address the day-to-day needs of at-risk populations. However, these organizations themselves are often vulnerable. So often these are nonprofit organizations or non-governmental organizations. When these organizations go through an emergency, they may exhaust their yearly budget for a response and not able to continue to provide services. So we need to make sure that those who are helping these populations on a day-to-day basis are resilient. And misconceptions. In the past, people with disabilities, for example, may have been perceived as unable to care for themselves, unable to function in daily activities, and unable to make decisions about their health and welfare. We know this is not true and that there's many strengths that we can harness from these groups. But because of these and other misconceptions, segments of the population are marginalized, causing systemic exclusion from the social environment. So now I want to talk about a couple of ways to address these barriers, and hopefully we'll be hearing a lot more about these successes as we hear from our other speakers. Collaboration. So we need to collaborate across all sectors. So for an example, during a response, the Portland Bureau of Emergency Management has social services and emergency management in the same room. So this allows them to work together and to build off their strengths. Engagement. The way we engage partners in the community, who we engage, and how we engage. So for example, the city of Berkeley ensures their community emergency response teams or their CERT teams mirror their community with inclusive and accessible training courses. So they offer it in a location where those who are disabled can attend, where you can get public transportation to it. They offer it during times when working parents can come in. They offer free childcare to make sure that those who are going to be responding look like the community that they're helping. Representation. So we want representation in our organizations, whether we're talking about our research organizations, our governmental organizations. So an example is the Bill Anderson Fund, which supports students from underrepresented groups as they complete graduate programs related to hazards, disasters, and emergency management. And so these students receive a fellowship to continue their studies and are mentored by other experts in this area to help bring more students from underrepresented groups into this field. So now I want to flip this lens. I've been talking about applying a health equity lens, and there's some of you in this room who may not work in emergency response, but the population that you work with, for example, individuals with HIV, are going to be impacted by an emergency. So have you thought about a preparedness lens for these populations? I like to say that everybody is involved in emergencies. And so we're going to ask these questions later on in the synthesis panel, but I just want you to plant a seed to be thinking about these. If you're working with a specific population, so if you work day to day in chronic disease, for example, have you considered how your population is impacted in an emergency? And while you're working to improve their day to day, are you working to improve how they will cope with an emergency? And for those of you who have been working in the health disparities field, how can you take your successes and help us apply it to emergency preparedness and response? So in summary, there's many social, economic, and health disparities at the root of vulnerability that persist during an emergency. We need to address the needs of at-risk populations in emergencies, which includes improving their day-to-day life. So can we address our social determinants of health and harness the strength of these groups? So for example, we know that a lot of minority groups have very close-knit societies. How can we take advantage of that and use it in emergency response? So I want you to think about how we can apply a health equity lens to address gaps and identify individuals and groups that need additional support. And likewise, how can you apply a preparedness lens to all health policies and practices to help build resilience among those most at risk? So I thank you. I think we're going to hold questions until after Dr. Bracci's presentation. Thank you.
Thank you, Dr. Walken. Our next presenter is Dr. Patrick Bracci. Dr. Bracci is currently the director of the National Center for Environmental Health and the Agency for Toxic Substances and Disease Registry. He came to CDC December of 2014 as the director of NCEH and ATSDR. Dr. Bracci leads CDC's efforts to investigate the relationship between environmental factors and health. Dr. Bracci came to CDC from Johns Hopkins University, Bloomberg School of Public Health, where he was on faculty for nearly 30 years. His primary appointment was in the Department of Environmental Health Sciences, with joint appointments in the School of Engineering and Medicine. He held leadership positions in numerous research centers, including the Center for Childhood Asthma in the Urban Environment, the Education and Research Center in Occupational Safety and Health, and the Institute for Global Tobacco Control. During his 30 years at Johns Hopkins, Dr. Bracci established a long-standing expertise in environmental health, as well as a strong record as a leader in the field. Dr. Bracci collaborated on complex health and exposure studies around the world, including studies in Peru, Nepal, Mongolia, Colombia, and India. He has published over 225 peer-reviewed journal articles and is a frequent presenter at scientist meetings and symposiums around the world. Please join me in welcoming Dr. Bracci.
Wonderful. It's great to be here this morning. So I'd like to talk to you about the Social Vulnerability Index that Dr. Walken mentioned to you a few minutes ago, and its role in incorporating social vulnerability factors into disaster management and planning. Let me begin by introducing a group within the Agency for Toxic Substances and Disease Registry called GRASP. GRASP is the Geospatial Research Analysis and Service Program within ATSGR. For over 20 years, GRASP has led the application of geographic methods for public environment health research within the CDC and the broader public health community at large. It's a multidisciplinary group of scientists that provide expertise and leadership in applying geospatial information through environmental, public health, emergency management, infectious disease, chronic diseases, and injuries. So it's important to realize here that we can visualize a lot of data. GRASP is a very powerful tool, as you'll see, for visualizing data, and you've already seen a little bit of that from Dr. Walken's presentation. I'll show you more. But it's also an important analytical tool. Remember, evidence drives policy, evidence drives change, and the ability to look at things in a geographic setting analytically is crucial for this. Now, let's step back for a minute and just talk about a little bit about the background and the rationale for the Social Vulnerability Index. When it comes to social vulnerability, there are multiple dimensions to vulnerability. There's a physical vulnerability, so you can be vulnerable because of where you live, in terms of whether you're on a floodplain, whether you're in an old building, whether you're near a volcano or on a earthquake fault. There are also health vulnerabilities that exist. You can be vulnerable because of some pre-existing health condition that you might have. But the focus of this talk is really about the social vulnerability. You can also be vulnerable, as you heard, because of the social construct in which you live, in terms of the transportation you have, the socioeconomic status you have, the many dimensions that have already been touched on today. So all communities exhibit varying degrees of vulnerability to potential disasters, both natural and man-made disasters. However, it's communities' social vulnerability that in many ways determine how well it responds to, recovers, and interacts with a disaster. So the social vulnerability refers to the demographic and socioeconomic factors that affect resilience in communities in order to manage these hazards. Studies have shown that socially vulnerable individuals are often less prepared for a disaster event, less likely to recover from it, more likely to be injured or die. Therefore, effectively addressing social vulnerability disease decreases human suffering and reduces post-disaster costs. This is the task that the GRASP Social Vulnerability Index took on for itself. So I don't want to go into a lot of the nuts and bolts, but I think it's important to understand that this is a very quantitative tool. And so what you see on the right-hand side are a series of social vulnerability factors that we can collect from a variety of databases. And these 15 variables can be further grouped into 4 major themes, which you see in the middle box. So these are things that deal with the social economic status, household composition and disability, minority status and language, housing and transportation. So these main domains are domains that we can use to assess vulnerability more broadly. We can quantify all the factors on the right-hand side, and we come up with scores. When you come up with scores, you can begin to be more analytical in how you address these issues. For example, you can see on the right-hand side, there are many characteristics that go hand in hand in a single event. So being able to quantify how these go along hand in hand is important. During the recent Camp Fire incidents in California, Many residents were in mobile homes and were older, so we have interaction between more than one of these social vulnerability domains. When these factors combine with low income, we can see how there's a lot of intersection among these domains in a single hazard. So looking at how they play a role by themselves and also looking at how they combine to create an overall vulnerability is important. So what I'd like to do is give you some examples of how this looks and how this works and how we can be quantitative about it and how we can begin to use it to make decisions about public health. So here we see a series of maps. Now, I'm a guy who loves maps. And when we used to travel as kids, you know, I used to sit there with that map in my lap following us as we drove down the road. Unfortunately, kids don't have that experience these days because nobody looks at a map anymore. They just turn on your phone, it tells you where to turn. But there's a lot of important information in geography and how things relate to where you are. We've known for years that there are many relationships that change over time, but we also know now that there's relationships that change over space. And to be able to incorporate that understanding into decision making is really what GRASP is all about. It's what the Social Vulnerability Index is all about. And it's what we need to be more aggressive at pursuing in our public health. So if we look at the right-hand side of this graph, you can see the 4 themes are mapped. And it's a little hard to maybe read, perhaps, but on the upper left is the socioeconomic status. The upper right is household composition. The lower left is race, ethnicity, language. And the lower right is housing and transportation. So just to orient yourself, as you can imagine, the darker color indicates a greater vulnerability. So already we can piece together some components of what it means to be vulnerable by looking at where these vulnerabilities exist. And these maps are produced over at the census tract level. And so we can see that there's a lot of heterogeneity in the vulnerability across these 4 different domains. Now, if we combine them all together into an overall social vulnerability index, we see on the left-hand side that we can look at kind of how they all come together. Recognizing, however, it's important that areas can have a low vulnerability in terms of one factor and high vulnerability in terms of another factor. While it's important to look at the overall vulnerability, it's also important to understand what the components of that drive that as well. Because you can be vulnerable with respect to one factor, not the other factor. That might drive what you do, what you think, and how you analyze your work. So, for example, the darker areas within the housing and transportation are areas where additional evacuation resources need to be employed. So if you're vulnerable in terms of transportation and you're told to evacuate, that's going to be a problem. So you know that already, just in terms of planning purposes, you need to make sure there's resources in order to get those transportation resources to those areas right away. You can also note that darker areas with socioeconomic status are areas where additional shelter resources might be needed because people with lower socioeconomic status might not be able to secure additional housing. They might have access to friends and relatives that live somewhere else. They might not have the resources to go to a hotel and so forth. So these are some examples of how we can look at these data. Now, there's an important document that I'd like to point out to you, and this is the document you see on the right, Planning for an Emergency, Strategies for Identifying and Engaging At-Risk Groups. This is a document the Center for Environmental Health Studies branch wrote with significant input from the SVI team. It includes a substantial section on how to use the SVI. So while I can't go through in a lot of detail today, we could talk for hours, and we have a whole symposium on SVI. I think this is an important resource for those of you in the audience who are interested in more data. So the SVI database can be used to identify areas of social vulnerability, target interventions. It can facilitate decision-making. It can be combined with other data sources to prioritize resources going forward. It's population-based. So you can target where the need is greatest. And it has other contextual information that can help you understand a little bit about a community's resilience overall, which can lead to planning purposes. So resilience, as you know, is the community's ability to prepare, plan for, and absorb, recover from, and more successfully adapt to adverse events. And we know that building resilience starts before disaster strikes. So while we clearly see the value of this information in the heat of a disaster response, the real value of this is in order to target resources before disasters hit so that we mitigate the effects that might be caused by these vulnerabilities. So let's talk about a couple of examples. So here we see a variety of maps. These are bivariate chloropleth maps. And what that means is there's two different colors. And when you combine the map overlays, the combination of colors creates a different pigment that allows you to kind of look at kind of where those two overlap. And so this has two sets of maps. So the upper right is the FEMA impact rank, and the lower right is the SVI rank during Hurricane Sandy. So the FEMA impact rank is based on surge, wind, and precipitation impacts. These are used to assess the impacts for each county based on the impact of the storm. The bottom right shows the the social vulnerability index, again, where the darker blue indicating areas of higher vulnerability, the darker colors in the FEMA impact also indicate greater vulnerability. Now, on the left-hand side, if you put the two together, you can see where the two vulnerabilities map together. The dark purple color indicates where high vulnerability is overlapping with high impact from Hurricane Sandy. This is a combination that, as we all recall, had devastating impacts. Now, it's important to look at the maps and to see how it plays out visually. But as I said before, it can also be quantitative. And a spatial cluster analysis revealed that there was significant relationship between the FEMA impact rank and the SVI, indicate there's a very quantitative relationship between the two. So this gives us strength in thinking that the SVI is in fact a good tool going forward. Now, if we look at a different impact, if we look at Hurricane Harvey, we can see that during Hurricane Harvey, the SVI webpage received over 22,000 hits in the 2 weeks before the Hurricane Harvey online. So this is obviously a tool that's being used a lot. And these are some data generated not by us, but by Harris County. And so similar to what I showed you before, the maps on the right-hand side show the 4 domains, and the map on the left-hand side shows the overall vulnerability index. You can see that there are many vulnerabilities overlap going forward. Darkest areas on the left map, but there are isolated areas, as we talked about before, particularly in the dark blue spot in the northwest borders of this county, where the high housing vulnerability and lower scores than most of the other things. So that doesn't mean we ignore those areas, but we have to focus on those areas where it's most important. So more importantly, Harris County used these data to look at mortality and morbidity. I don't have these data. The state of Texas has these data. But they found, for example, that approximately half the deaths that were in census tracts with an SVI in the highest quartile, meaning that with SVI we can expect more mortality. They saw a similar result in terms of morbidity. So going forward, we can also see not just that there's greatest impact, but it actually leads to health disparities as well. Now, this is an example that's probably closer to home. This is in Georgia, and it looks at heat-related morbidity and mortality. So similar to what we saw in some of the other storms, we can look at the overlay between, on the left-hand side, ED visits, and on the right-hand side, mortality. And we can look at areas where there's high morbidity and mortality, areas where there's high social vulnerability. If we get to the bottom line of this graph, we can see that with every 10% increase in SVI, the rate of heat-related ED visits increased by 20%. So again, the ability to be quantitative about these relationships is key. For every 10% increase in overall SVI, the heat mortality rate increased by 30%. So heat events are going to be with us now. They're going to be a regular part of our life. And so planning for these, using these data to identify where the morbidity exists, where the mortality exists, and how it relates to vulnerabilities tells you what you need to do to intervene. So this is crucial for our public health moving forward. Now, there's many partners who work with ATSGR on using these data, and we list some of them on this slide here. We don't have time to go through all the different roles, but the Social Vulnerability Index has a big following across the public health community. So in conclusion, disasters and emergencies are an everyday part of the world. In many cases, what we used to consider a rare event now are a common event. So extreme heat events, wildfires now are things that we deal with every year. Historically, these events were rare, but now they're more common and they're more complex. This makes SVI tool even more important. Every part of the nation and the world is constantly being affected by these events. For more information, please visit the SVI website, interactive maps at svi.cdc.gov. see more examples of how this is being used, you can look at some of the publications listed on that website. Lastly, I'd just like to thank the people who are responsible for developing the index. You see them listed here. So Andy Dent is the director of the GRASP program. Erica Adams, Elaine Halsey, Barry Flanagan, and Greta Wilt are all important contributors to the GRASP program. So with that, I think we can move to questions and answers.
Thank you, Dr. Bracci. So for questions, we have the mics in the middle aisle there on opposite ends. And then if we want to, okay, no question, IPTV. So the floor is open for questions for Dr. Walken and Dr. Bracci at this time.
Thank you for those really fantastic presentations. So a question about the SVI, how often is it updated? Is it a continual updating because things change, gentrification happens? How often do you keep that current?
Have that here. So the SVI is produced with databases for years 2000, 2010, 2014, and 2016. And so it relies on the census and other data. We're looking at producing a 2018 database once those data are available going forward. So as the census data becomes available, we revise the SVI index going forward. So currently, it's the most recent data are based on the 2016 data. Everybody's always shy in the morning. Somebody's moving down. If those of you who don't have microphones at your desk, you can step to the microphone in the aisles.
Sorry, took me a while to lumber down the stairs. This is a question for the first speaker. I noticed that you mentioned that you do have a focus to some degree on the resilience of responders. I was wondering if you could elaborate a little bit more on that and what you do around that area.
Yeah, in the Center for Preparedness and Response, so not out of my group, out of DEO. I don't know if any of them are here today, but there, yeah, I do see some of them. There is a big focus on responder resilience. We want to make sure that we are thinking about our responders, that they're going out the door as capable as they are and have the proper training, and then that we supply support to them during a response. And through NIOSH in the system, there's ways to register your responders and then track them and follow them so that you can watch their resilience. And then it's an important piece when they come back home too, for them as well. But it's recognizing that they're going through a traumatic event potentially as well, and that event could be re-engaging some previous trauma that they've had also. So it's very important to think about.
I'm sorry, I think I misunderstood and thought you were talking about those out in the States.
I mean,
it was like state-based public health. So, but to that end, I also wanted to then, I'm sorry, that wasn't a setup question. I also wanted to put a plug in so I just became the team lead of the resilience program that's associated with our occupational health clinic. And I will have to say that before I knew about the job, I didn't know they existed. And I think that that's probably very prevalent across the agency. So we're working on trying to improve that. But I was also curious what others in the States do. And I'm sorry, I think I thought that was what you were referencing. But this is an opportunity to let CDC folks know that there is a dedicated resilience program that's based in the occupational health clinic.
Yep, and we'll have the opportunity to hear more about that later today too. Thanks.
Good morning. Great presentations. Thank you. I wonder if the vulnerability index includes populations like those that are incarcerated and those that are undocumented, because we know they're around, and how do you account for those populations?
Well, I think the undocumented populations are a challenge because there's not a lot of data on them by definition. But there are opportunities where there's not national-based data for a state to include special factors about vulnerability. And so if a state was willing to incorporate data where they have it available, they could certainly do that. And with respect to the incarcerated populations, I believe it's in there, but I don't know for sure. But that would be an important group to consider. Yeah, it's in group 4. Incarcerated populations are in group 4. Which is in the theme of housing and transportation. Thank you.
I'm going to try again here. Can you give us some examples of where states have used the SVI database in preparedness, and how has that helped the state level response or national response?
Yes. So the Harris County example is, I think, a perfect example, where they looked very carefully at during the 2017 hurricane season, where the damage was, where the vulnerabilities were, where the morbidity was, where the mortality was, and they were able to focus resources aggressively in those areas where they think they needed it more strongly. So I think that's a good example. And if you want to refer to the website, I think you can see more examples of how states do it. There was a comment up front.
Yes. Hi. Good morning. Excellent presentation. I want to share with you my experience in Puerto Rico. We reached the community leaders of different population groups, and we found there more information that we can do it by assessment by people that go and interview people. Members of that community, because the community leaders know the needs of the community, knows the person that really are in a real need, and help us to figure out how we are going to address the problems of the community in general, because the problems of the communities are different island wide. The problem that is in one community is not the same than in the other community. Could be water source, could be accessibility to healthcare, you name it. So I think that maybe in the future we have to involve more the community leaders in this type of vendor board, because we can get more fresh and real time data about the real situation of those communities, and the people that are more vulnerable.
Thank you. I think that's well taken. In fact, this data was meant to be used by local public health officials to drive the response and to work on preparedness activities.
I just want to comment on that. We do say all disasters are local because we recognize that, and these are national systems that gives us a starting point. But we have a research project right now, which was actually piloted in Puerto Rico to collect information from local leaders. And so at the end of this research project, there will be an app that local leaders can use to help find out how to get that local information from your community leaders, whether they're lay leaders, elected officials, because we know that is the best information that you can get and should be used to drive the response. So thank you for mentioning that.
Great presentations. My question is, with the SBI, has there been any effort to partner with, say, for example, local non-governmental organizations as a way to give aid? So using SVI as a way to kind of promote aid, because I know there was, I think, almost $1 billion given for the Houston hurricane, and people were saying they weren't sure where to, I guess, put the aid.
Yeah, I think there's lots of examples of that. So they work with the Catholic Charities. They've worked with a group called Direct Relief to create an interactive map identifying vulnerable populations during the Houston hurricane response. They even worked with legal services corporations to provide legal services to disadvantaged populations as well. So I think there's a host of examples where there's nonprofits that can use this information as well to help guide their efforts.
Okay, we have one question from IPCD, and the question is regarding immigrants in that highly vulnerable population. I know you spoke about this a few minutes ago, but the question is, how can we ensure that immigrants don't remain invisible during emergency response? And what do we do with that?
So that's a great question. Certainly is one of the at-risk populations that we need to consider. Not only do they have a lack of resources, but they're often marginalized. They don't have the political power to garner resources. There can be language barriers, and we call them. Some people call them hard to reach populations, but they're we need to make more effort, and we also need to make that sure that there's policies in place that people can access the resources we're giving. A lot of times that's an issue. For example, in California during the drought, they were giving out water, but undocumented people didn't want to come get the water, afraid about other repercussions. So it's really important, and when we're putting out recommendations and policies, making sure that everyone has access to them, including our immigrant population. So no easy solution, but definitely on the minds of everyone.
Keep in mind that SVI is a tool, right? And it's designed to incorporate data where those data exist in a platform that can be useful for policymakers, private citizens, nonprofits to address these issues. And so as a broader societal issue, we need to kind of think about how do we gain access to data on immigrant populations. And then if those data become available, it would be relatively straightforward to incorporate that in the SVI tool.
Okay, one final question. Go ahead.
Yeah, thanks. It's not really a question, more a comment. Thank you for the great presentations and all the great work with the SVI and so on. I just wanted to comment on a couple things that have already been said as far as, SVI being used by the state. For instance, in Texas, they were concerned about immigrants and undocumented people. And so even though the data, as Dr. Bracci said, is difficult to really get and incorporate completely, there are local organizations who, already work with these groups and who try to reach out to them. And so when we were in Texas, we were able to meet with those groups, and they were able to use an SVI map to also sort of incorporate where they knew these people worked and lived. And so, it's useful in that case. Another point I think that Dr. Walken was making was that all of these organizations, it's not just up to public health, it's not just up to emergency management, but we realize now after Texas and Puerto Rico and, USVI and these other things, that there's a whole broad range of sectors, as Dr. Walken said, who didn't know that they were involved in emergency response and recovery until these really large-scale events took place. And all of a sudden, we realized that we have Department of Housing and, Department of Aging and these other organizations who weren't ready to do this, really, but that their role is so important because they're the ones who are protecting a lot of these populations before an event takes place. So that's an important, I think, lesson that we've learned, particularly in this from the 2017 year. And just lastly, I think when the question is how do we reach these people, the other thing we need to learn is where are these folks and how are they getting information? So in Texas, for instance, some of these folks had the day laborers collected in a certain place in the morning. That's where they were, and that's where they needed to be reached. Other folks say that in some communities, it's in churches. In Texas, we found out that there was a large Vietnamese group, fishermen, coastal folks, who are not going to come to the disaster resource centers. And so, we found out where they were and tried to get the appropriate people to go and address the community leaders there. So, it's all interconnected, but I thank you for the presentations that I think will set a good stage for the rest of the morning. Thank you.
Okay, thank you. Again, I want to thank Dr. Walken and Dr. Bracci for very informative presentations.